All right, let's talk about something that can feel a little intimidating for a lot of us, the oral exam. It can be tricky for sure, but our goal here is to give you a simple, systematic way to look at any lesion you see and feel confident about what to do next. Okay, let's kick things off with a number that's, well, it's pretty startling. One study showed that while over 80% of internists in the hospital think oral exams are important, this is how many actually do them routinely. Less than 20%. I mean, that's a huge gap between what we know we should be doing and what's actually happening on the wards. So, what's behind that gap? Well, it really boils down to this. The study found that most clinicians just didn't feel confident in their exam skills. And that uncertainty? That's exactly what we're going to tackle today, to help you turn that hesitation into a really clear, confident approach. So here's our game plan for this explainer. We'll start by digging into that confidence gap. Then we're going to build your systematic exam from the ground up, learn to spot what's totally normal, and then get into decoding the common white, red, pigmented, and ulcerative lesions you're going to see. And we'll wrap it all up with a clear action plan. Okay, so let's get into it. Why does this confidence gap really matter? Because the mouth is, it's like a window into the rest of the body. If you miss an early sign of cancer or a clue to a systemic disease, that can have some really serious consequences. The problem isn't that people don't care, it's that they often lack a structured, repeatable way to do the exam. And this chart, wow, it just lays it all out, doesn't it? Look at that huge bar on the left. Almost everyone agrees these exams are important. But then you see that tiny little bar on the right showing how often it actually happens. That's the gap we're here to close. All right, so how do we fix this? Let's build that systematic approach together. We're going to give you a simple, repeatable toolkit. And you know what? It doesn't start with looking. It starts with listening. The patient's story is your first and honestly, your most powerful diagnostic tool. So, before you even reach for a tongue depressor, these questions start building your differential diagnosis. How long has it been there? Has it changed at all? Are there any other clues, like a fever or a rash somewhere else? And you've got to ask about medications, tobacco, and alcohol. Every single answer is a clue, another piece of the puzzle. Okay, once you've got the history, it's time for the physical exam itself, and you have to be methodical about this. First things first, get a clear view. Ask the patient to take out any dentures or retainers. Second, zero in on the lesion, look at it, and feel it. Third, do a full sweep of everything else in the mouth. And last, don't forget the extraoral exam, face, neck, and lymph nodes. You can't skip any of these steps. One of the biggest things that builds confidence is just knowing what's normal. There are so many things you can find in the mouth that look a little scary but are completely benign. Knowing these friend variants will save you and your patient a whole lot of unnecessary stress. Let's look at 3 super common ones you're going to see. Leukodema has this cool little party trick. It's a grayish film on the cheek that actually disappears when you stretch the skin. Fortis granules? Those are just tiny, harmless oil glands. And physiologic pigmentation is just normal coloration, especially in people with darker skin. Your job here is to see them, know what they are, and confidently move on. Okay, so now that we've got the normal stuff down, let's move on to the real deal, the pathologic lesions. White and red patches are incredibly common, and our job is to figure out which bucket they fall into. Is this benign? Is it an infection? Or is it something we need to worry about? Now this is a classic matchup you need to know. On one side, you have frictional keratosis. Think of it like a callus in the mouth, maybe from a denture that doesn't fit right. It's totally benign. But on the other side, you have leukoplakia. It can look similar, but it's a diagnosis of exclusion, a white patch we can't explain any other way. And that is considered potentially malignant and needs to be followed closely. See how important that history is? Speaking of white lesions, let's talk about oral candidiasis, or thrush. There's this awesome clinical pearl here. If you take a piece of gauze and you can literally wipe off the white plaque, revealing this red, raw-looking base underneath, your diagnosis is almost certainly thrush. It's such a simple and useful bedside test. But here's a key contrast. While thrush wipes right off, oral leukoplakia does not. You can't scrape this one off. It's caused by the Epstein-Barr virus and often shows up as these white, kind of wrinkly patches on the side of the tongue, especially in patients who are immunosuppressed, like from HIV. That inability to scrape it off is the key thing that tells you it's not thrush. Okay, so this all leads to the single most important question, right? With all these different possibilities, which are the lesions we absolutely cannot afford to miss? Which ones should set off alarm bells for potential cancer? And thankfully, the answer is a simple but really powerful clinical tool. For any lesion that's been hanging around for 3 weeks or more, you have to apply the RULL acronym. Just think of it as your safety net for catching oral squamous cell carcinoma early. So let's break down what RULL actually stands for. R is for a red lesion, or one that's mixed red and white. U is for an ulcer. L is for a lump. And E is for especially when you see these things in combination or if the lesion feels indurated, meaning it's firm or hard to the touch. If a lesion fits the RULL criteria, it needs a biopsy, period. All right, we've covered a lot on red and white patches, but of course, there's a whole spectrum of other things you'll see. So now let's quickly touch on 2 other important categories: pigmented lesions and ulcerative lesions. Let's take a look at this table comparing 3 big causes of oral ulcers. Aphthous ulcers, canker sores, they usually pop up on the movable parts of your mouth, like the inside of your cheek. Herpes often has that classic tingling feeling before the blisters even show up. But if you see a patient with recurring ulcers in their mouth and on their genitals, you have to start thinking about systemic diseases like Behçet syndrome. Now, when it comes to pigmented lesions, context is absolutely everything. You see a blue-black spot right next to a silver filling, that's almost guaranteed to be a benign amalgam tattoo. A simple flat brown spot, probably an oral melanotic macule, which is basically a freckle. But oral melanoma, while it's rare, is incredibly aggressive. You have to evaluate it with the same ABCDE rules you would for a skin lesion. Whew! We have covered a ton of ground, haven't we? We went from the confidence gap to the nitty-gritty of specific lesions. So now, let's pull it all together into one final, actionable framework that you can take with you to your very next patient. So let's boil it all down into your 5-step action plan. 1. Always start with a good history. 2. Do your systematic exam, both inside and outside the mouth. 3. Know your normal variants so you don't chase zebras. 4. If anything looks suspicious and it's been there for more than 3 weeks, apply the RULL acronym. And 5, and this is the most important one, when in doubt, get a biopsy or refer. And really, here's the bottom line. You don't need a special clinic or a ton of extra time to make a huge difference. Just like this quote says, simply working a good oral exam into your routine physicals, that kind of opportunistic screening, is a totally feasible and effective way to catch things early. Every time you see a patient, it's an opportunity. So, I'll leave you with this question. Now that you have a systematic approach, you have the tools to look with real confidence and actually see what's there. The only question is, what are you going to find on your next exam?